Today we will discuss a very interesting topic. At least it's very interesting for me. It's fMRI-guided transcranial magnetic stimulation for refractory migraines. I'm Alexander Mauskop, director and founder of the New York Headache Center and professor of clinical neurology at State University of New York, Downstate Health Sciences University. So here's an outline of the presentation. First, we'll talk about some definitions of migraines, different types of migraines, and what is fMRI, what is TMS, and then we'll talk about fMRI data specifically in migraines, and then we'll talk about the use of transcranial magnetic stimulation in migraines, and then fMRI-guided TMS for refractory migraines. I'll tell you some case reports that I've encountered. And then we'll talk about what's necessary to move this idea along. So migraine is defined as at least 5 attacks occurring over a period of time and lasting 4 to 72 hours. And then the headache has to have either 2 of the features, unilateral pulsating quality, moderate severe intensity, aggravation with light physical activity. So you have to have 2 of those 4, plus you have to have 1 of the following ones, and that's nausea and vomiting and photophobia and phonophobia. Of course, patients don't fit necessarily into this neat classification. So there are people who have migrainous headaches or more likely to have headaches, but that's mostly used for research purposes, where we can have a very narrow, very well-defined group of patients where we can do clinical trials. And then there is also a headache called chronic migraine, which is an arbitrary condition that is arbitrarily defined by headache specialists to be a headache that occurs on 15 or more days each month for over 3 months and fulfilling the following 2 criteria. It occurs in a patient who's had at least 5 attacks prior to the onset of chronic migraines. And then they have to have at least 8 days in the month fulfilling migraine criteria, and they often have other kinds of headaches. Yeah, very arbitrary, because many patients who have milder headache that's not a migraine still might have a very mild form of migraine. So it often is migraine every day, but some of them don't fit the classification. So again, this is mostly for research purposes. You don't need to use it in daily practice. If the headaches are frequent, persistent, we call them chronic migraines. Migraine, as you probably know, is extremely common. 12% of the population suffers from migraines, 18% of women, 6% of men. And chronic migraine, that is migraine that occurs on at least half of the days, and often every day, 1% of the population, which is a very, very large number. And people with migraine-related moderate to severe disability comprise 40% of migraine sufferers. And migraine is the second leading global cause of disability and is estimated to affect 1 billion people. And you might be curious, what's the first leading disability? And that is back pain. About 70% of the population, at least once in their lifetime, suffers from back pain. Now, migraine often occurs with other conditions. It's not necessarily in isolation. So if you have migraines, you're more likely to get depressed, you have anxiety, and other pain syndromes, because your brain becomes sensitized. So you can have fibromyalgia, irritable bowel syndrome with stomach pains, back pain, and then it can cause insomnia. PTSD coexists, and insomnia mentioned caused by migraine, but it actually often coexists, not necessarily caused by migraine. And then increased GI bleeding, often because of the medications that patients take. And there is comorbidity with epilepsy and cardiovascular diseases and other conditions as well. So what is a refractory migraine or resistant migraine? European Headache Federation. I quote the European Headache Federation because the American Headache Society has not come out with a definition yet. There's a lot of discussion. We have lots of meetings about what to call refractory resistant. So in Europe, resistant migraine is a migraine that does not respond to 3 or more classes of preventive drugs. And refractory migraine, that's the most commonly used term by most headache specialists, a refractory migraine. And that's a failure of all classes of preventive drugs. Well, I don't know how you define all classes because there are so many of them, and I'll show you the list of things that we have available. So refractory migraine, probably not all classes, but maybe 5, 6, 7 treatments that don't improve the migraine, then we will call a patient refractory, or rather having refractory migraine. So resistant or refractory migraine is extremely common. This was a survey of doctors who have an interest in treating headaches, neurologists and headache specialists, and 50% of their patients had a resistant and 30% had a refractory migraine. And in specialized headache clinics like ours, 75% are resistant and 46% are refractory. And many doctors have low, moderate confidence in managing these patients. So this is the study that I'm quoting, Burden and Attitude to Resistant and Refractory Migraine, a survey from the European Headache Federation with endorsement of the European Migraine Headache Alliance. So as I mentioned, we have many treatments, non-steroidals for acute treatment of migraines. Triptans, there are 7 triptans in the US. Gepants, rimagepant, ibrogepant, or Nurtec, Ubrelvy. And we have zavegepant, nasal spray also, missing on this slide. Then there's all drugs, dihydroergotamine, opioids, which we rarely use, short course of steroids, neurostim devices, nerve blocks, and so on. And as far as preventive therapies, botulinum toxin is probably the most effective and safe treatment that we have, but fairly expensive. We often have to start patients on beta blockers to satisfy insurance requirements before we can move on to Botox or CGRP drugs, which are actually endorsed by the American Headache Society as the first-line drugs. So some insurers actually allow us to use those before trying what's called step therapy, trying first a beta blocker, then an epilepsy drug, antidepressant, and so on. So we have many options, and this is just a partial list of most commonly used ones. I wrote a book called The End of Migraines, 150 Ways to Stop Your Pain. Actually, second edition has 160 items, and my third edition will have probably even more. So the point of this book and the title is, there's always hope. We never run out of options. We always have to try new things. And that is why I started using Botox over 30 years ago when there was little evidence. Just like with fMRI-guided TMS, there is not a lot of evidence, but a lot of circumstantial evidence. With Botox was even less. But because it was safe, I decided to plunge in and try it, and eventually it did get the approval because it is a very effective treatment. So what is fMRI? It's a non-invasive imaging technique that measures and maps brain activity by detecting changes in blood flow. It's the so-called BOLD signal, blood oxygen level oxygenation dependent, blood oxygen level dependent signal. When the brain region is more active, it receives more blood flow, which changes the magnetic properties detected by the MRI scanner. So it's a regular MRI machine, but it uses a different software. It provides real-time images, and it's of different functions. So it's used for functional disorders of the brain. There's no radiation, just strong magnetic fields. And it's used by many neurosurgeons now to plan surgery. For example, if you have a brain tumor in a very sensitive area, speech area, for example, they want to map it out and make sure they can spare the important regions of the brain. There's a lot of research on studying various brain functions and diagnosing and planning treatments. People with strokes, TMS is used for stroke rehabilitation using fMRI images, but we'll move on to data suggesting what's wrong with patients who have migraines on fMRI imaging. So there have been several studies. This was very thorough studies that identified neuromarkers with abnormal functional connectivity and visual cortex and default mode networks and sensory motor and frontoparietal networks. So it could discriminate migraineurs from healthy controls at 93% sensitivity and 89% specificity. So pretty accurate. Then they did a second study to see how generalizable this marker is. So they took a separate independent cohort of migraineurs, and they found 84% sensitivity and specificity. And the third step these researchers did is compared the marker in migraines with other chronic pain conditions, such as back pain and fibromyalgia. And then the sensitivity and specificity was about 78, 76%, differentiating migraineurs from other pain patients. And this is a nice visual from that same study showing actually, you see on the circle on the right side, that the occipital area is very, very much involved in migraine pathogenesis here. This disruption of the networks to the occipital lobe play an important role. And then there was another study looking at functional connectivity. And in this study, language networks were most predictive of migraines. And it's true that people often have difficulty speaking, and they also have other cognitive disturbances. In this study, besides language networks, also visual and, again, visual occipital lobe and medial temporal regions were also involved. This is yet another study looking at functional connectivity in migraines, and they found strong connectivity issues between bilateral cuneus and right cerebellar areas in post-traumatic headaches compared to healthy controls. So this was not a migraine, post-traumatic headaches. And another study entitled Aberrant Cerebral Blood Flow and Functional Connectivity in Patients with Vestibular Migraine. That's the type of migraine that's often hard to treat. These patients may have headaches, or they sometimes just have vestibular symptoms such as dizziness and brain fog and other associated symptoms. Some have migraines as well. And we do have a specific classification identifying what is called vestibular migraine. But again, that's mostly for research purposes. If someone has pronounced dizziness or vertigo, then we call it vestibular migraine. And in this study, looking at specifically vestibular migraine patients by IHS definition, there was increased functional connectivity between the right precuneus gyrus and the areas of the left posterior cuneus gyrus, and decreased functional connectivity between left insular regions on the left thalamus and right anterior cingulate. So that shows you that these studies detecting anomalies in different parts of the brain. There are some common findings, like the occipital lobe, visual cortex, is often involved in cingulate cortex. Those are common themes that go through these studies. But again, it's still not clear. And I don't think there will be ever one type of anomaly that will be applicable to all patients, because as we know, migraine is a polygenetic disorder. In every patient, it has a somewhat different manifestations. So I think that we won't be able to find one target for TMS that is defined by large studies. It will be more likely to be an individual approach in these patients. So what's TMS? Transcranial magnetic stimulation is a treatment that's cleared by the FDA. Devices are not approved, but they're cleared. The FDA allows them to be used, as opposed to migraine drugs and other drugs where you do a large study proving how it works, and then it's FDA approved as opposed to FDA cleared. So all the devices, neurostim devices, are only cleared. So FDA cleared TMS about 15 years ago for major depressive disorder, people who don't respond to antidepressants. And it's also approved or cleared for obsessive compulsive disorder in adults if they're treatment resistant again. And the certain TMS devices are cleared as an aid for smoking cessation. And there is some suggestion that it also helps other addictive disorders. So addiction can be an issue as well. This is an outpatient procedure. People come in and they're awake, no anesthesia. They just have a coil placed on the scalp. Doesn't look like a coil. It's a thick, I'll show you a picture of what it looks like. The reason it's so thick is because there's a cooling device inside, because TMS causes heat, the coil to heat up. So that's, you sit there for 10, 15, up to 45 minutes. And the typical course of treatment that's FDA cleared for depression is 5 days a week for 6 weeks. So it's 30 sessions, very intense. But we find that twice a week still produces good effect. When this was approved for depression, they didn't do dose ranging studies as we do in medications, meaning that they didn't compare once a week treatment versus every day, 5 days a week for 6 weeks. And there is a very interesting research going on at Stanford. I visited their lab. Nolan Williams developed accelerated protocol for severely depressed patients who are on suicide watch in the hospital. And they do 10 short sessions throughout the day, and the average time to discharge is like 3.5 days, so highly effective treatment. And they use functional MRI to define the areas where to stimulate, because the approval here, the clearance by the FDA, applies to one spot. Left dorsolateral prefrontal cortex is all you have to do, stimulate that area, and depression gets better, OCD. Sometimes OCD has additional areas of stimulation as well. So we have a device, actually, that's FDA cleared for migraines. It's called Savvy Dual, device by Neura. It's a single pulse transcranial magnetic stimulation in the occipital area. And as you see, there have been several studies showing that it actually is effective for the acute treatment of migraine, that is when the migraine begins, and also for prevention. If you use it regularly, it can have a preventive effect. And this is what the device looks like. It's like a little brick. You press the button, it charges up, you press the button, you get a click, and you do several clicks. For acute therapy, do 3 pulses, repeat it up to 3 times for each attack, and preventive use is 4 pulses twice a day. So you charge it up and use it. So it's only 4 pulses. What probably is more effective is RTMS, that is repetitive TMS with multiple stimuli, like a couple of thousand we do in our practice. So there have been studies, several studies, but small studies. So this is a meta-analysis of 8 RTMS studies, and it showed that RTMS was more effective for decreasing migraine attacks than the sham RTMS. And the meta-analysis also showed that it's effective in reducing migraine attacks even when just dorsolateral prefrontal cortex is stimulated, just like with depression. However, the RTMS did not reduce the pain level. Here's another meta-analysis, and this one revealed, that was published in 2022 in Cephalology. It showed that meta-analysis showed that high-frequency, repetitive transcranial magnetic stimulation over, again, dorsolateral prefrontal cortex significantly reduced acute medication intake and functional disability. However, no differences were found in headache days and pain intensity. So here are a couple of samples of specific trials. Those were meta-analyses, and this was so the first study, RTMS over the vertex at 1 hertz. And again, there are issues also unresolved as to what's the ideal frequency. It's considered that low frequency stimulation, like 1 or 2 hertz, it produces inhibitory effect on the cortex, while high frequency, like 8 to 10 hertz, produces activation. And then in case of depression, the reason that left dorsolateral prefrontal cortex is stimulated, because it was found that that area of the brain in depression is disconnected from other parts of the brain. So stimulating it, activating that area, improves the connectivity and improves depression. The next one, RTMS study, was stimulating, again, that prefrontal cortex. There was no difference with placebo in that study. Again, these are very small studies, 5 in placebo arm, 6 in RTMS arm. Next one is high-frequency repetitive TMS was found to be effective. Again, open label study, small study. Not as small as previous ones, 50 out of 51 patients had a greater than 50% reduction of headache frequency after 3 RTMS treatments to left dorsolateral prefrontal cortex. And improvement persisted until the 4th week and 80%. Well, if I see 98% improvement from any treatment, clearly there's a major placebo response as well, because I didn't expect any treatment to work more than maybe 70%. 60, 70%, as we see in Botox or other very effective drugs when you compare it to placebo or sham treatment. So it's a very good signal that it works, but I would not believe the 98% number in any trial for any treatment, because again, as I mentioned, migraine is polygenetic and very variable among patients. And just one more study to show that RTMS actually can be effective for other pain syndromes as well. So this review of pain trials published in 2023 suggests that use of 10 hertz high-frequency RTMS at the primary motor cortex can help reduce neuropathic pain, especially patients with spinal cord injury, diabetic neuropathy, postherpetic neuralgia, and other conditions that have been reported to respond to RTMS, post-stroke pain, brachial plexus injury, radiculopathy, fibromyalgia, phantom limb pain. Again, these are anecdotal reports, not really studies. Interesting fact is that motor cortex is what produces pain-relieving effect rather than the sensory cortex. So it's consistently motor cortex that's been shown to reduce pain. We don't know why, but that's very consistent across many studies. Safety of RTMS, it's extremely safe. People sometimes get scalp discomfort. This magnetic coil touches your scalp. You hear a clicking noise, and sometimes it causes unpleasant sensation, in which case we just reduce the intensity of magnetic stimulation headache, ironically. It makes a lot of clicking noise, and you sit in one position, so people get headache and neck pain because sitting in one position for half an hour. Lightheadedness, I've seen patients feel sometimes nausea, tinnitus. Occasional syncope has been reported, and seizures are very, very rare, but people worry about this possibility because you stimulate the cortex. But seizures have been found to be extremely rare. This is a review of 318,000 TMS sessions. 24 seizures, only 4 of those occurred in patients without any risk factors, without any pre-existing conditions. So seizures are extremely rare and not of major concern. And actually, there are a couple of researchers looking at TMS as a treatment for seizures. So in our experience, I have to give credit to my former resident, Dr. Gayatri Devi, who is a memory specialist. And she uses RTMS for enhancement of memory and other neurological disorders. And she treated a few of most refractory patients. One patient was on 80 milligrams of OxyContin because of migraines that got worse after a skull fracture, trauma. And another patient was taking 20 Furisets, butalbital, aspirin, caffeine combinations, 20 pills a day for 20 years. She was able to get them off it within a couple of months. So that's what prompted me to get into this treatment area and purchase the equipment, which is quite costly. And it seems to be quite effective. So we use treatment at dorsolateral prefrontal cortex. Sometimes we use bilateral motor cortex, or Dr. Devi uses it low frequency stimulation at parietal cortex. And because there is a device that's FDA approved for migraines and shown to be effective, again, FDA cleared for migraines, and that's purely stimulating occipital cortex. Sometimes we use left DLPFC and then bilateral occipital cortex, depending on the patient's symptoms. So ideally, again, we have patients come in at least once a week. And if they've traveled from outside New York City, from far away, we can do 5 days a week for a couple of weeks. And sometimes that produces very good results. And we try to find, for patients who travel from afar, local practitioners who can do that. Some psychiatrists are willing to add additional stimulation sites that we find to be effective in these patients. We found someone actually in London for 2 of our patients, and they're doing very well there with continuing treatment. So post-traumatic headache, possible therapeutic target of transcranial magnetic stimulation. This is a study that showed that if you just stimulate standard DLPFC site, the results will not be as good as if you use a specific target. The same with the psychiatrist Nolan Williams at Stanford. He uses his high frequency, that is accelerated protocol based on fMRI data. And this study for post-traumatic headaches compared the standard DLPP side and optimized, because dorsolateral prefrontal cortex area is fairly large. So if you just use a center point of that area, the results may not be as good as if you actually define where the most anomalous area is. So targeted repetitive TMS seems to be more effective. Again, this is a small study, so the results not definitive, but suggestive that if you're more specific as far as targeting, you'll get better results. This is an example of what we see when we do an fMRI scan with presets specifically developed for migraines. And this is, again, software developed by Omniscient Neurotechnologies. The darker the color, the more anomalous the connections, the more connections that are overactive or underactive. The darker purple, there are many more. And the way we work it is that you see this one is being marked for export into our neuronavigation machine. So we look around this image, see which ones are the darker ones. If they're on the surface of the brain, we just mark them for export. And this is the yellow one just appeared there. It's a very common spot for migraines. It's called 8AV area. And we also can mark each spot that is dark and make it appear with all its connections. So if we click on that yellow spot, and because it's deep and we cannot reach it with TMS machine, once we show the connection, then we can see where it connects. So even if a deep structure is not functioning properly, has many anomalous connections, we can still target that indirectly through another site that is more superficial. So this is what the setup looks like. On the left is what we call a neuronavigation unit. We load up the regular MRI, if that's the only thing that's available, or an fMRI with targets. And that allows us to find the spots on the patient's scalp. And then on the right side is the TMS machine. We use a machine made by Mag Ventures, 4 or 5 manufacturers of this equipment. And this magnetic coil, as you see, is fairly thick because, as I mentioned, there's a cooling liquid going through it because it gets hot with repetitive stimulation. And by the way, that patient allowed us to show his image even on our social media. So a couple of cases of what we've encountered. This treatment obviously is a last resort treatment. We have, as I mentioned, over 100 different things we can do. But if a reasonable number of treatments fail, like in this patient, 61-year-old woman who's tried antidepressants, blood pressure medication, epilepsy drugs, Botox, CGRP, injectable drugs, and oral, and nothing worked for her. And then we did 7 TMS sessions, our TMS sessions, at left DLPFC and bilateral motor cortex. Results were not as impressive as after we did an fMRI and found anomalies at different areas, including a visual area. So the results got better with this treatment. Again, it's very hard to measure objectively. How do you measure that? Placebo response is always an issue, but these people are very refractory to treatment. If it works, chances are some kind of other treatment would have caused the placebo reaction, like Botox injections is also fairly dramatic, but it doesn't always work. And this is a 17-year-old girl, also had very good results. She was very happy after 25 TMS sessions. She had definitely improved in mood. You could see that she was, when she first came in, was barely talking, just sitting there, looking very unhappy. At the end, she was much more interactive, talkative. Headaches improved, but still, she still had headaches. And if she strained and looked at screen for a long time, she had difficulties, and so she wasn't able to go back to school. So we did an fMRI to see if we can specifically target better areas. And in fact, like in most cases, fMRI images showed areas that we were not treating that were good targets. And she continued to improve after we did the fMRI and changed the stimulation sites. Another woman was 40 years old, new onset severe disabling headaches, typical migraines, again, failed to respond to many treatments. She did fMRI from the outset, and then we identified targets and treated her. And she, quote, said that TMS gave me a long weekend with my family, including Father's Day. For the first time in 3 years, I'm more resilient. And she comes once a month or so, or whenever the headache gets worse, she comes in, but she's much more functional and enjoying her life a lot more. So there are several obstacles to fMRI-guided TMS and treatment of migraines, mostly because fMRI scanning is available in a research institution. And because I'm on faculty at medical school, I have access to the fMRI machine, and we do have to pay for the privilege of doing fMRIs because they usually take twice as long as a regular MRI. And then there is a secondary issue of fMRI analysis. And all those studies I showed you about fMRIs use different software, different processing. It's another source of possible disagreement. That is, processing is not standardized. We use an Australian company called Omniscient Neurotechnology to process the data. Patients often ask me, can I see a picture of my fMRI? Yes, we can see the specific areas, and we can look at language areas. We can look at attention. We can use sensory motor areas. So there's a wealth of information, but there's no single image. There's no report. You just look around, and we have specific presets developed by Omniscient Neurotechnology, looking at migraines, anxiety, depression, and we often add, if there's a strong anomaly on anxiety or depression presets, we add those areas to stimulate as well. So that might all get better with the power of artificial intelligence to process huge amounts of data. So it might become easier and less expensive. Again, the biggest obstacle, it's not a proven treatment. Insurance companies often don't pay. Occasionally, if the patient has comorbid depression or tried several antidepressants, they might cover partially if the patient has out-of-network insurance. So what we need now is accumulation of more fMRI data and maybe correlating the fMRI data with genetic data and other markers, biomarkers for migraine to see if there is a correlation. And then we need controlled RTMS studies to get FDA clearance for that specific indication, which would allow some insurance companies to pay for it. And eventually, hopefully, that will happen. But it's a very long road because of all the obstacles I just outlined. But we are very excited to have an extra tool for desperate patients who have tried everything possible, almost everything possible, and nothing is working. So this is an extra thing that hopefully in a few years becomes mainstream. And this is a painting by Jean-Michel Basquiat that looks like a headache that I like. And this is my daughter's painting. at the beginning and the end of this lecture. If you have any questions, feel free to email me at drmauskop@nyheadache.com. I hope you found this presentation useful.